Peterborough NHS Foundation Trust. Lovely to have you with us. As ever, we've got a full agenda, but a really interesting agenda also. And I'm going to, without further ado, move into that part of the meeting where we have the opportunity to hear from and learn about some of the initiatives that the Trust is involved with. And to that end, I'm going to hand over to Sam and Louise to talk us through something called Project Cavell, which is not actually about the Cavell Centre in Peterborough. But obviously, here in the east of England, we are very proud to be associated with the name Cavell, so it gets used for many things. And in this case, you're going to talk to us about Project Cavell. So we're in your hands, or Operation Cavell, to give it its proper title. Thanks, Louise.
Thank you. Good morning, everybody. My name is Louise Sheldon-Tabor, and I'm the Head of Risk Services here at CPFT. And I'm really pleased to introduce to you this morning Operation Cavell, which is a joint initiative between CPFT, Cambridgeshire Constabulary, and our criminal justice partners. At its heart, Operation Cavell is about ensuring violence, aggression, and hate crime against our staff is taken really seriously, with a really key message that abuse is just not tolerated as part of their jobs. This work's been developed over the past couple of years with strong partnerships, robust governance, and we're now moving into planning stages. Whilst I maintain strategic oversight of this work stream, it's fair to say that the person that deserves all the recognition is Sam, my colleague, and this work's been led to date by Sam, and Sam's now going to talk you through the progress to date.
Thanks, Lou. Morning, everyone. Everyone's happy. I'll go straight into it and what you keep up my northern accent.
We love your northern accent. Thank you.
Okay, Operation Cavell and the key message: no excuse for abuse. Next slide, please. What is Operation Cavell? It's an NHS and a police initiative that was created back in 2021 to change the way in which violence, aggression and hate crime was handled by the police when it's committed against our staff when they come to work. Now, it's quite difficult because there isn't a central register for this, but to my knowledge, around 12 trusts across the UK have implemented Operation Cavell or some version of Operation Cavell. So when we had the opportunity to look at this and possibly implement it 2 years ago, we grabbed all of it with both hands. So yeah, essentially for the last couple of years, through careful communication with Cambridgeshire Constabulary, the Crown Prosecution Service, and various individuals within CPFT, we've arrived at a version of Operation Cavell which works, or we believe works, for us as a trust. So the aim is to improve investigations, improve reporting, victim engagement, very much with a victim-centred approach, to support proportionate resolutions and a whole range of other things, which I'll elaborate on as we go on. Next slide, please. Why is change needed? Quite simply, many of our staff, unfortunately, when they come to work, they do experience violence, aggression, abuse and hate crime. We know that happens, and unfortunately many accept that as part of the job. But what Operation Cavell is about is getting the message across that it should not be accepted as part of the job to come in and experience these things, and for some, on a daily basis. We've had historic challenges, including early filing crimes. So, for example, it could be at the point of reporting at the call centre or from the officer in charge, when we have a case that relates to mental health or mental ill health, and quite often it can be filed because it's a mental health matter, not a police matter. Operation Cavell addresses that directly, and again I'll elaborate on that shortly. This subsequently leads to low confidence from inconsistent updates and limited engagement from officers, and contributes to the why bother, nothing ever happens kind of perspective. Next slide, please. So the strategic fundamentals of PACT. One of the key points here is it recognises our staff as emergency workers. Fortunately, while our staff do fall under the Assault on Emergency Workers Act, it hasn't always been applied. A staff member could be assaulted and it's been classed as a common assault, whereas Operation Cavell brings about a different perspective and it will be categorised as an assault on an emergency worker. So yeah, it very much brings that into focus. We want to improve investigations, increase community engagement, better communications with victims as part of the victim-centred approach, and also with CPFT, with us, as we work on a regular basis to liaise with the police and with victims to manage police cases and support in a number of areas. In addition to this, there's the wider proportion of resolutions. Another important point of this is previously when something hasn't been able to go down the criminal justice route for whatever reason, it's quite simply been filed. However, now, ingrained within the process will be a very conscious look through communication with the victim, a range of out-of-court resolutions. And this will include various things from apology letters, consequence sessions, anger management sessions, again as part of the victim-centred approach to reach some form of resolution, even when it can't go down the criminal justice route. Culture change, this is a massive part of it. We really want to make a change in culture and really make a difference. You know, this is a passion on both sides from CPFT and Cambridge Constabulary. That is not just part of the job, it shouldn't be accepted. Challenge the assumptions around mental health. And also just to get the message across to increase reporting, because without reporting, we can't paint the picture, we can't understand the full scale of the problem. In addition to that, if staff are keeping it to themselves, we can't direct them to the range of kind of the welfare facilities that the trust does offer. So we need to keep in touch with that and keep abreast of what's going on to support our staff through their incidents. All of this and more is summarised in the acronym PACT. Okay, so put the victim first, assume capacity unless there is clear evidence to the contrary, as per the Mental Capacity Act. Consider all options, such as the aforementioned out-of-court disposals, and to take positive action. The positive action is a key part. It's about doing something, making a difference. Next slide, please. Thank you. Okay, so we aren't going to just simply implement Operation Cavell and say it's perfect, it's brilliant, there we go. We're going to hold it to account. There's going to be a monthly partnership meeting involving representatives from CPFT, from Cambridgeshire Constabulary, and it will include ward managers and service managers and people from the ground to really pick it apart and find out what's working, what isn't, what we need to tweak to continue to improve things and make things better. But a more finalised version that works best for us as a trust, more importantly, works for staff. We'll look at police investigations and the victims' code of practice on the police side to make sure they are listening, they are responsive. We'll look at the amount of resolutions and out-of-court disposals that have been applied. There will be a continuation of the welfare focus. And quite simply, overall, we're looking to measure staff confidence. We want staff to feel more confident, safer coming into work. And again, to create that new culture that there is a point in reporting and we can make a difference. Next slide, please. Implementation and next steps. So we've prepared a trust-wide communication. We are just finalising that to make sure the message as shared between Cambridgeshire Constabulary and ourselves is very clear to get across to the trust what Operation Cavell is, what we are trying to achieve, and specifically where you can get guidance, where we can get support on this. And there will be a centralised resource once we go live with that, with a range of resources, such as key documents, but there will be quick reference guides on calling 999, preserving evidence, reporting on DATEX regarding some of the restructuring we've done, and understanding how call centres categorise risk when they are facilitating a response from the police, and a whole range of other things. And this includes posters and staff-facing materials and a whole many other things. We've worked with Datex to refine and improve the violence and aggression, and specifically the police reporting sections, to remove ambiguities, provide clearer definitions, and hopefully make reporting a little bit easier to continue painting that picture. We've implemented staff surveys, and within the monthly partnership meeting, quite simply, we will be scrutinising the perspective before Operation Cavell and afterwards as well, to look at the staff confidence. We are introducing ambassadors. So we have agreement on all sides that representatives from CPFT, the call handlers of Demand Hub and Cambridgeshire Constabulary are essentially going to sit down in a room with a little bit of mediation, probably. But we're going to have some frank conversations, and there's a full commitment from all sides on this to break down the barriers of communication, to understand what it's like working in a mental health environment, to ambiguities around certain acronyms and terminologies to make things easier, to understand what our staff are trained to do, what they can and what they can't do, and that's a very important point. And this will be ingrained in the training on both sides. And again, we have a commitment from the police that this will be ingrained on their side, which is very important to this, obviously, as well as ourselves. So it has been 2 years in the making, but I'm very glad to say that we expect this to be implemented by the end of June. We are aiming for 2 weeks from now, but certainly by the end of June, we are almost there. And to be honest, I'm quite excited about it, making a genuine difference, because yeah, we certainly expect it will do. Next slide, please. Finally, just some points to note, just to reiterate the partnership approach. Okay, for a consistent victim-centered response to violence, aggression, abuse, and hate crime. Okay, so it's listening to the victims and actually being responsive and engaging and providing welfare. To advocate the no excuse for abuse message, to say there is a point, and the message to continue reporting, paint the picture, let us know what's happening, let us support you. And fundamentally, this is about, I'm repeating it, but this is that culture change. It's to make a difference. We want to say something happen and staff to feel safer. Okay, with that being said, I believe that is me. So thank you very much, and I'll hand over to Lou.
Thanks very much, Sam. That is the end. Well done. Thank you, Eileen. So
No,
we'll take any questions.
Thank you both. Really important subject you're bringing to the board today, and I think honestly, thank you to 2 years of hard work. Thank you to our partners as well for the fact they're really taking it seriously. And I think you'd want the board to say we've never believed that there was any excuse for abuse, and that the more we can tackle meaningfully the ways in which abuse is dealt with, and to ensure our staff don't come to work feeling that there is no remedy if they experience such things, the better it will be. Because some truly horrible, we should not shy away from that. Some truly horrible things can and do happen to our staff, and we always want to support them, but we do need to make sure that channels are open and for there being consequences to action. Rudolph, in you come.
Thank you. That's great, and I'm hugely supportive of the initiative. The one thing that I just want to be flag up is that there's a little bit of discussion about capacity, including in the acronym. My understanding, might be wrong, is that capacity is not really the relevant question, it's about criminal intent. And I just wonder that if we focus on capacity or have assessments around that, that we may miss the slightly different test of criminal intent. And so as we're monitoring this, I think we'd just be keen to see that we get a sense of whether we're creating any confusing messages or misinterpreting the police and misinterpreting.
Yeah, absolutely. And unfortunately, you know, it has been 2 years. There is a lot to it. You quite rightly asked that question. Through part of the communications with the Crown Prosecution Service, they have very clearly stated that at the early onset of investigation, they don't require confirmation of capacity.
I would suggest at any point, because one, there's not a test of capacity to commit a crime. That's right.
No, absolutely. And it's not about criminalising mental health. It's about, we've created an additional process to allow investigations to take place where appropriate through the inclusion and development of a fitness to the interview form, which has been through our medical advisory group and lead psychiatrists and others to make sure it is fit for purpose. And that took quite some time. That was one of the key sticking points because we wanted to get it right. And quite simply, the template as we've created is being used to push out across the wider east of England even, and possibly the wider UK. But it's a very important point of what we'll continue to monitor.
I bring in Stephen and then Mark.
So, look, I just want to say a big thank you, first of all, because actually, you know, we got a agenda item later on the board, public board, around sort of our staff survey. We hear feedback through that around sometimes how people feel being on the receiving end of, say, a potential assault or, you know, so again, look, a big thank you. And I know this work has taken a lot of time and effort over the last couple of years. I mean, I think you partially asked my question around, we talked about that sort of feedback loop and learning and sitting down on a monthly basis with the police. But obviously the CPS have an important part to play in this, in taking that forwards. And are they part of that sort of that learning feedback loop, or is it just very focused around working with the police?
No, there's a number of people involved, because when the idea of Operation Cabal was first created, it was through partnership with the NHS and policing and the Crown Prosecution Service. But again, it's just a very basic version, so that's why we've developed our own. And yeah, that's included a lot of communication with the Crown Prosecution Service to understand what they need, what we're able to achieve, and the complexities of our environment as a trust. That certainly includes elements of mental health as well, and they will be involved in ongoing communications and scrutiny.
Thank you.
Mark.
You're going to have a great initiative, and well done for keeping up the effort for 2 years to get it kind of in place. You mentioned about the recording. I mean, are you comfortable that the recording system is where it needs to be? Because one thing which makes people report is the ease of reporting, being able to get it kind of initially registered. Also, you've got ones which may go to the police, others which may not go through to the police level. And then it's the feedback loop to the individual of what's happening when they raise an issue, hearing back of either it's taken forward this way or what's going to be done. Because again, that then encourages more people then to report even more. And then finally, it's then taking all that recording information, then saying, is there any lessons to be learned? Is there a particular site which is more problematic, or a particular service which is more problematic? And therefore, then you may be able to target kind of initiatives in particular areas which may make the greatest difference. So it's, again, in early stages. So I think it's more, the more we can make it easier for people, the more we give them feedback, the more we then use and then seem to be using the information to actually help our staff. I think the greater kind of benefits will come from it.
Absolutely. As mentioned, just very briefly in there, we have been working with DATEX to refine the violence and aggression and police sections within DATEX, and there's always room for improvement. And the reporting system is robust. But quite simply, it's just about getting the message across, I think, because when the relevant people are included within the communications, when an incident happens, it's just about just reinforcing things with the managers and the people on the ground, if you like, just to say, are you okay? You know, because quite often, if something involves a police case, if a staff member has suffered some form of hate crime or violence, quite often, because as soon as we get it, we get a notification, we are directly in touch, finding out if the staff member is okay, can we support? Has this been reported to the police? Will this be reported to the police? Yeah, but we need to keep our finger on the pulse. Yeah, that's the bottom line. Thank you.
Go to Pri and then Jackie, and then I think we're going to have to draw to a close on this item.
First of all, thank you. It is really important that we keep reiterating the message that any unfair treatment of our staff, whatever form it takes, is not acceptable. I have 2 questions, but hopefully quick ones. You mentioned about treating staff as emergency workers. Is the difference in that actually the impact on the perpetrator? Or is it a sense of protection plus the impact on, I guess I wasn't quite clear that I understood that piece.
Yeah, apologies. Essentially, at the point of reporting, when it becomes evident that an assault or a hate crime has been committed against a member of staff whilst at work, it's automatically categorised as an assault on an emergency worker. Essentially, what that means on the police side is they put a pin in it and say, look, guys, this is Operation Cabell. It's automatically escalated to a sergeant at that point instead of a lower level. And they all go, right, okay, we are being held to account for this. So they make sure they pay more focus and pay attention. And in terms of categorisation of offence, the assault on emergency worker is essentially more serious than hate crime assault. And we know that can vary, in terms of seriousness.
That's helpful. And a very quick one, in terms of committees and board and governance, where will we see the impact of this once it's rolled out formally?
So there will be a monthly partnership meeting which will happen amongst Sam, Cambridge Constabulary and the CPS to discuss as per the slides, and then we will flow that up through the Workplace Risks Group, the Health and Safety Committee, and then to B&P, and unless we have any further discussions about needing to potentially flow the information elsewhere for awareness as well. So I think it covers a number of different committees because of the widespread impact, and so I think there might need to be some.
Thank you.
Okay, Jackie.
Yeah, thank you, Sam. Thank you, Louise. Really, really interesting. You mentioned 12 other trusts that had joined in. Are they kind of ahead of us, or are we in a pack in terms of a timeline? And is that a network of a learning community that's being built there in terms of sharing knowledge and experiences and learning and doing things differently, similar?
There's no central database, unfortunately, possibly quite surprisingly, around how many trusts have implemented, but I did spend some time to try and look and investigate it. And part of a national performance advisory group that I attended is try and gauge how many trusts, and it's approximately 12. I don't know how many it is exactly, but they are, or they can be very different versions, and it was implemented in 2021. Essentially what we've done as a trust is, I know through other arenas, it's been stated that the work we've done has put us in a, I won't say ahead of other trusts, but in a very good position, which is why our template has been used or pushed out across the rest of East of England and again the wider UK.
We're a trailblazer.
Always.
Good answers.
Please, briefly.
Yeah, so just a final word, really, and it's a really simple word. It's thank you. Sam and Lou have just gone through the governance. They've gone through the reporting. They've gone through the framework. They've gone through how staff can reach out if they need support. They've gone through the connection with multi-agency. This is a really complex piece of work, but what's been presented makes a lot of sense. It's a very sophisticated set of partnerships. And the last couple of sentences at the end of Sam's presentation used the word culture. This is a massive step in the right direction for this trust. We talk about culture a lot. We promise to changing culture. This is part of that, Sam. And so on behalf of 5,000 people who work for us, thank you. Because this is about making sure they are safe and they feel valued and supported when things in our sector can get tricky. So all of this is done through you and the team, and the relationship with the constabulary, sometimes that can be fractious. And the Chief Police Constable and I have had a conversation about this, and this is a very definite partnership. So I just wanted to say a huge thank you for doing that bit as well as the governance bit.
On that happy note, you may choose to race out of the room before it's now starting. Huge thank you. I'm sure everybody who's been listening in will have been both interested and very impressed with what you're doing. And we'll look forward to hearing from you again as to how it's going. That proof really will be in the pudding in terms of how well utilised it's been. Thank you so much.
Thanks very much.
Thank you very much. All right, everybody. everybody. Then into the main section meeting. Firstly, I've not been notified of any issues today, so we're not with me. I did want to note though that this is the last public board meeting for our Dr. Kathy Walsh. And, I think I'm sure there are many things we'll miss. The number of meetings you attend may not be necessarily. I'm sure others will speak to your departure. Thank you for being such a faithful attender here and for the contributions you've made. And we welcome beside you Catherine Maxey, currently your Deputy Chief Medical Officer, who's going to be the acting Chief Medical Officer when you depart. So Catherine, it is lovely to have you with us today. I want to note sad news formally that someone that a number of you may have known over the years, someone who was the chair of EPUT, partner trust of ours in ethics, a lady called Hattie Llewellyn Davis, passed away recently. Hattie made an enormous contribution to the health system in the whole east of England over many, many decades. I first knew Hattie over 30 years ago when she, in former incarnations of NHS structures, held a regional role. Then she went to work in various provider trusts in chief executive posts. She's somebody who truly did care about good health and good impacts, and who's left us far too young. So we remember just for a moment Hattie who has left us. And then we move on to that part of the meeting where I ask if anybody has discovered a new declaration of interest to delight us with. No? Okay. In which case, then I will go to the minutes of the last public board meeting held in March. And I'll go through first for accuracy, and there are 16 pages, so bear with me. On page 1, page 2, page 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, and 16. I think we are agreeing with that record of our last meeting. Martha and Natalie for 37 minutes. Are there any matters arising out of those that aren't covered in the action log or elsewhere in this meeting? Okay, so then I go to the action log, which has one item on it, which is perennial with us around the ECT provision in the south of our geography, where I think Holly and Stephen were due to see a business case in July. I suppose my question is, are we going to see a business case, and is it going to move things forward?
Thanks, Irene. And in short, I think through various discussions with both directors who are affected by this issue, along with Stephen, and we agreed yesterday that we would look at a slightly different. We know that actually a business case to provide authority on this site is going to be very challenging for a number of financial and operational reasons. And actually, we've also done some benchmarking with various institutions, what challenges they have, how they are trying to address having accessible services, and we have found that actually organisations that have one centre rather than more sort of locally based centres And I think where we got to, having grappled with this issue for at least a couple of years, but I think in my tenure, but the longest since post-COVID, we discussed that we needed to take a different approach and actually look at how do we make the most of the facility we've got, and then how could we safely ensure that patients who aren't local to that facility or who aren't NWAF or the bell could access that facility, because I think we recognise that it's probably going to be building a facility. So yesterday we agreed that we would get together a small group, including clinicians, to understand actually what the work stream looks like. We recognise that taking that approach still leads to inequity in terms of location, but I think we're all really keen to understand how we ensure that all the patients who need access to ECT have a way of getting that benefit, recognising that for some patients that will be a long journey time.
All right, Rudolph.
In that vein, are we making plans to ensure that someone that is, for example, in CUH and has a mechanism, for example?
Yes, we are. So actually, Catherine mentioned that in terms of what would an outreach sort of service look like.
Yeah, we discussed that Rudolph. That's an area where the biggest patient risks sit, I think, and unmet needs sits within our CUH patients who can't physically travel up to the Cabal. And we discussed one option around how we would ensure that a service that's geographically based in North has a specific outreach function that's resourced and safe to travel to CUH.
All right, I'll await updates on that, Holly. I think we want to reiterate though, as a board, that ECT has been found to be a life-saving treatment. You argue that they're not mental illness that are being addressed, but other life-saving treatments for illnesses. There might be more public outcry around access to services, and it's we are very mindful. Thank you for that. I've not been notified of any other business, Martin. All right. So we'll move to my report, and it is a busy meeting today, so I don't plan to delay you too much by my commentary. But you will see that I've noted that we have a new Secretary of State, and we welcome him into his post. Being the Secretary of State for Health and Social Care is an immense responsibility to take on, and we wish James Murray well in what he does and what he undertakes. I think he's somebody who does have an informed and serious interest in mental illness in particular, and we await whatever pronouncements he may make on wishing to take forward some of the promises that his predecessor made around the process of working towards greater parity between mental illness and physical illnesses. So I hope very much we may hear from him and move forward around what the plans are in his department to bring that to life. So a bit of a theme today in terms of inequity in health. You'll see in my report that I drew out that in May we had Dementia Action Week, and I think it is worth, just for the public record, pulling out, not my words, but those of a former colleague of mine, Michelle Dyson, who's now running the Alzheimer's Society, who I think says far more eloquently than I would do. What is the issue that many of those we work with and those we serve are trying to solve? And she says that in the digital age of instant answers, people are still waiting far too long for a diagnosis of the country's biggest killer. This would never be tolerated in cancer care, yet for dementia, it has become routine. At every stage, people are missed, symptoms are missed, diagnosis is delayed, and support often comes to be the lifeline so desperately needed by people with dementia and their loved ones. This is not a backlog problem, it is a system that is missing people at every stage, and while the system waits, dementia progresses, stealing time, independence, and dignity. While politicians race to cut waiting lists, people with dementia aren't even in the queue. I think those are very powerful statements. I think it's also true that almost everybody in this room and everybody online will have had a life that has been affected by knowing somebody who lives with or is experiencing dementia. So it is a national disgrace, and I use the word advisedly, that we're having to rely upon a charity to call out the fact that we aren't doing enough. We as a trust are doing our very best with the resources available. And I think we should be inordinately proud of the work that our staff undertake absolutely every day in the area of dementia care and support. And equally proud of the work that our staff undertake around dementia research, which is genuinely world leading and which we should be extremely proud of. But it could be even better if sufficient resources were put towards dealing with what I repeat is now the biggest killer in this country. So I'm going to stop at that point. I've used Michelle's words. I hope you get the sentiments that health inequalities are inequalities because they're never priorities for systems. And dementia, access to healthcare will always be a priority here for us. We want to see more support for those illnesses which appear to be being neglected, misunderstood, or not fully funded. On that point, Steve, I will hand over to you, your Chief Executive.
Can I just people speak towards the microphones? We're getting quite a few comments about the same quality externally.
Okay, I thought we had fixed that.
Which we have, it's
Okay.
Just for clarity, Martin, are they in the sea?
green lights.
Okay. Just, okay. I'll speak up and up. I think I'll just
Look to the heavens.
look to the heavens. Yeah, a bit of divine inspiration. Good morning, everybody. Thank you for joining us. Thank you, Chair. I think on the note of introducing Secretary of State James Murray, I think on behalf of the board, welcome into the role and congratulations on the appointments. I met with James yesterday with a group of colleagues, and I think it was pretty clear that the Secretary of State has A, been fully briefed in the 2.5 weeks it's been in post, and then B, is really clear in terms of some of the actions that he wants to take forward. What is really reassuring is Secretary of State has confirmed additional commitment to the delivery of the 10-year plan, which means that the work that the NHS has got underway at the moment on delivering that is not slowing, and therefore momentum won't be changed because of additional change. I think James indicated a sense of greater focus around the use of digital in supporting the NHS's movement forward, particularly with the roles around the use of artificial intelligence, AI, in many areas, and then a heavy sense of the word prevention in terms of what we can use AI to enable us to do differently. The Secretary of State also mentioned some of the frustrations that are coming from the leadership community, and both empathised and sympathised with that, with the view of taking those forward into the office in terms of recommendations and priorities moving forward. One of which is working with agencies around resident doctor industrial action, of which I'm very sad to inform the board that there is another conversation happening at the moment of potential industrial action looming in front of us. The Secretary of State had confirmed that conversations, negotiations were really clear underway with colleagues such as BMA, and steps being taken there in terms of ways forward. I think it's also safe to say that both government and the NHS is going as far as it can to support a lot of the challenges that are being made by our resident doctors. So this is around supporting collectively the way forward, and being clear on the impact that some of those issues can create, not just for our patients and for our for their carers, but also for staff that have to support this industrial action. We will be on our 16th round of industrial action moving forward, which is something the NHS has to support. Moving quickly into the report, so I think since we last met as public board, we received the King's Speech, so we would welcome the narrative within the King's Speech and a lot of the direction that has been laid out there. And again, in accordance with delivery of the 10-year plan for the NHS, the evolution of NHS England and Department of Health and Social Care to create a single entity to clarify and streamline reporting lines, to look at where some of the priorities are sitting within the NHS, and also hopefully to start to unbuckle some of the bureaucracy that we have to deal with when we're starting to talk about some of our clinical priorities. Within the King's Speech, there are a couple of things that have moved forward, which I'm sure you'll see on the news around the bill that is traversing through its various decision-making at the moment. We will brief colleagues accordingly as that starts to unfold. But there are some very welcome things for our sector sitting in there. And one thing that I was particularly pleased about yesterday was a commitment from Secretary of State that parity of esteem for mental health and community services remains strong in the conversations around acute care, general practice, primary care, and a range of other services. Moving into that, on the 12th of May, we were able to celebrate International Nurses Day, so a small drum roll for our chief nurse, who did a brilliant job working with our comms team, supporting, I'm going to go on a limb, Rachel, nearly 1,800 of our registrant nurses, talking about the role that they play, not just on that day, but every day. And they are a vital member of our workforce and often go above and beyond. The word discretionary effort with our nursing community couldn't be said more strongly enough. Our nursing community go the extra mile every single day. And then before I get shouted at, as do all of our other services and all of our staff around the table. But I think on the day of the 12th, it was nice to recognise that for our International Nurses Day. You'll see that we are moving quickly with regard to some of our initiatives and innovations, the use of AVT, colloquially known as ambient voice technology. I won't go into detail here, but moving quickly with our digital strategy, which is an enabler to making things easier for our workforce. This isn't replacing things, this is making easier changes, things such as logins, such as I'm looking at Rudolph Assist2 technology, which is the utilisation of smart cards. All of these things are quality of life issues for clinicians that have to log in 3-4 times to get into various systems. And the digital team are working strongly with them over some of our systems, such as System 1, etc., to make it easier to use and get the right data at the right time. So that's really positive and moving forward. And then this month also included our Learning Together Festival, which kicked off, and a big thank you actually to our learning and development team, talking about embracing leadership, embracing what it means to be a leader. And Sam and Lou gave a brilliant example of 2 people leading for this trust, leading on an initiative, sticking with it until the end. But the work that they've done has impacted on 5,000 people straight away, and they are leaders in their own rights. And it was really good to power that up over the last couple of weeks. My particular thanks go to Jazza Amaranto, Dr. Christine Sykes, Andy Kwana, and Joe Fishpool for joining me at the beginning of the session, talking about their role in leadership and their leadership journey. I have to say, show bias immediately in this, but the 2 stars of the show, sorry Joe and sorry Christine, were Jazza, who's one of our ward managers, and Tandy, who's got a significant richness of experience and leading out for us on safer staffing and our PCREF. It was really, really powerful to hear about their journey. And you don't have to be an executive director or a senior officer to be a leader in an organisation. And that demonstrated it through and through. Big part of a cultural shift for us as a trust, powering up the people who make a difference every single day. So that was fantastic. And I'm happy to leave it there, Chair, and answer any other questions. But I think I just want to end on the fact that I'm really pleased to see Sam and Lou come and present something today that they've been incredibly proud of, that is going to make a massive difference. More of that, please. because we see this every day, but I'm not sure the board sees this as much as you'd like. So with your agreement, I think we'd like to bring a bit more of that around the table.
I think we'd all welcome that, and I hope people can hear well. We thought we had dealt with all the gremlins on sound quality, so I'm just going to keep checking with Martin that you can hear well. I think, Steve, we need to move to the board assurance framework.
Thank you, Chair. So the board assurance framework is different this time on the basis that we have talked to the board about lifting this up to be a more strategic document, and therefore what we have included here are our key board assurance framework, risk management board assurance, BAF as it's called, our key risks. So you'll see those captured in the paper that is included. Please don't worry about the fact that they're all amber red, and the reason why they're amber red is because that's why the board is alerted to those being significant risks. All the ones that are green, in track and being delivered don't get raised up to the board. So it's not that everything is amber red, it's the fact that this is what we report. The other nature of this is the fact that board assurance frameworks, by the nature of the risks that they present, should not change quickly, and therefore they are strategic issues that we navigate through. They could be environmental, they could be within our landscape, they could be political, or they could be stuff that is on our agenda that is difficult to move. And so I am really pleased, and thank you to Martin, who has presented this through our committees of the board and had a range of conversations with everyone around the table. Martin, is there anything from you before I close on that point?
It's just I intend to bring the refreshed back to the private board on the 1st of July.
Fantastic.
The email this morning, Steve.
Lovely.
And also on the assurance ratings for the benefit of the board members, just to confirm that process going forward. I've written on the 1st of July as well. So we're all working on the same arrangements going forward.
Thank you. And Chair, it's probably safe to say that in terms of summary of risks on page 4 of this report, one of the things that I'll be working with the team on is a review of the target risk that we're trying to acquire rather than the current, because the target risks should by default be a lot lower if we are clearly heading in the right direction for something. But as it stands, I want to take the opportunity, as Martin says, when we do the refresh, to bring that down.
Mark and then Mike.
I mean, the only thing is your target may be right. So it's not a case of that everything should go down to 1s or 2s. But I think maybe another column at the other side where you say at target or not. So then if it's green because you're at target, there's nothing more you're going to do. That's the level of risk that will always be there, but you don't have to worry about it, even if it is amber, because that's the nature of the activity. Whereas other ones which are you're out of target, then of course you want to do. Sure. But that's why I think periodically there's a discussion regarding are our targets at the right level? Yes. Do we feel that it is appropriate or we should now reduce it because we've reached it and we think we can go further?
Thanks, Mark. And in terms of the contractual part of my brain, these are things to rebase and rebasing them at times around our strategy, around our planning and around changes to the landscape or politics is super useful. So we won't just fix this and leave it alone. I think that's a really good point, well made.
Mike.
It's really just an observation and to thank Martin. So the board assurance framework requires us to make an assessment of how assured we are. And I just wanted to thank Martin for taking on the job of clarifying how we go about that and make sure it's uniformly applied, particularly at subcommittee level.
Excellent. I mean, I think it's probably true to say that in that listing of risk, we probably could boil it down to 3 key important buckets, one being culture, one is about quality of services, and the other is about money. And it would be surprising if those were not the 3 principal areas that are taking our time as a trust to really work through. Okay, if we could move on then, we'll go to quality, safety and patient experience matters. And Mike, to you on the quality, safety and patient experience subcommittee.
Thank you, Chair. This assurance report refers to the meeting that we held on the 23rd of April this year. And if I could just draw out a number of points. We've already discussed ECT, which is an important treatment for affective disorder or resistant depression. And I wanted to expand on that a little bit in that at our last meeting, we talked about a clinically led piece of work across the system led by CPFT, colleagues at CPFT, which is to look at how we approach affective disorders more broadly. There are a number of treatments which we currently don't offer to that group of patients. And this aligns with the ICB's intention to have clinically led transformation work. It aligns with our clinical strategy of the trust, and it aligns with the suicide strategy that sits across CPFT. So ECT sits within that piece of work, I think. The assertive outreach service, which is now up and running, I think we should congratulate the team for taking that through, getting the funding, and I understand this service began operating last month. We've mentioned the patient and carer race equality framework. I just wanted to highlight that Jackie Dyer, NHS England, led she's the mental health equity advisor for NHS England, and she led a very successful session in May with staff considering how we approach KEEP-CREF, patient care and race equality framework. We continue to address the issue of timely responses to complaints, and we are approaching that with an internal audit, a rapid process review, and we have actually changed the working day target and extended that to 60 days. You might be, well, the safeguarding report was given partial assurance, and this is because of the numbers and complexity of safeguarding issues have increased, and the risk associated with that has been escalated to the operational risk register, which is why we gave it assurance. I also want to congratulate Karen Davis, who's now chairing the Trust Carer Programme Board, and I was pleased to be able to join that meeting last week. Final couple of points. Clinical effectiveness report. This is looking at our compliance with national audits and the like, but we were particularly pleased to hear that the links between audit findings and quality improvement work in this trust are being strengthened. And the Reducing Suicide Group report, that group is expected to produce its final report later this year in October, so we look forward to that. And very finally, could I just call out the contribution of our two patient safety partners to the work we do with regards to quality and safety is very important. And that's Bob Braggett and Naomi Rose. And they not only contribute to the work of the team, but contribute in multiple ways across the trust. And I think we should acknowledge that publicly. And similarly, the Quality and Safety Forum that's led by Miriam Martin is going very well. And I think that's developed some very helpful conversations between the executive, non-execs and the governors. And so that forum is maturing. And I'm pleased that it's chaired very ably by Miriam Martin. Happy to take any questions.
Steve.
Thank you, Chair. Thanks, Mike. Really good update on the report. I think it's really helpful to reflect on some of the services that we are talking about strengthening. And I think one of the areas that's particularly important is the fact that a lot of those services have been running in the organisation for quite some time. And it is really good to see those formalising with different models by commissioning, which I think is part of certainly the reset that we've done around the range of those services. So I think it's just really worth noting that those services have been running for a significant period of time, or a version of them, and formalising them into a more fidelity-based model is super useful. So something that we'll be bringing back through quality and safety as other services start to develop too. Thank you.
Well, the only thing I might come back on is just, I didn't mean to say it and forgot, this business about affective disorder and the proper management or the optimal management of patient with depression. So that links into our developing primary care strategy, because quite a lot of the burden of care of patients with depression falls there, and the relationship between the specialist services we offer and primary care services is currently being actively considered.
Super helpful, thank you. Thanks, Steve, for that clarification. Steve.
Thanks, Eileen. Yeah, thanks, Mike. Just one query on the complaints, and really good to see the rapid improvement programme underway. Is there a timeline for that we can share?
Can I defer to Rachel?
Yes. So in terms of the initial phase of the rapid improvement work, the QI advisors are working with the complaints team, or QI advisors.
Just to explain what QI advisory is.
Sorry, Eileen. Our quality improvement advisors who work directly in terms of the PDSA cycle of whether it be process mapping, PDSA being plan, do, study and act, and going through the improvement cycle. They're working very closely with the PALS and complaints team. They are in the month of June, so they've done all the process mapping. In the month of June, they are now having sessions with the directorates alongside to agree the more formalised improvements in terms of escalation, etc. I am hoping that we will look to see change by the end of this month. Obviously, from a reporting perspective, that will take some time to flow through. The other aspect, I'm probably doing a segue into my report. The other aspect is that, which Mike talked about in terms of the target and the policy change for that, we are now in line with system partners. And then the other component is that our internal audit, RSM, Robert has some time ago requested internal audit, and I don't know the timescale for that. Robert, do you know the timescale for that?
No, but it's planned for this year's annual audit plan, so it will usually be still working, of course, on analysing 25-26. We do the annual report and accounts, so I expect it to be doing that within the first second quarter, so either next month or 3 months. Right, follow that up, check when they start that. It's a key part of the internal audit plan.
I think it is probably worth recording that we have been round the buoy on improvement plans in complaints a number of times now, and have had not dissimilar processes described to us. So I think we would want to get a good deal of assurance, and maybe RSM is one route to that we are actually going to start hitting the target regularly and consistently in terms of our responses. Bearing in mind that if you're waiting for a response, it can be quite a stressful period as well for people. Okay, thank you, Mike. Thank you, Rachel. Rachel, we stay with you, I think.
Yes. So that was one of the points I was going to raise in my reporting. The other area that I want to raise is in terms of what Mike has rightly raised in terms of the sexual, the safeguarding issue, the risks within the trust, and it's important to acknowledge, and obviously I think everybody understands, whilst the excellent work from the safeguarding team in terms of improving safeguarding under safeguarding training, etc., has meant an increase in contacts and advice guidance that is therefore requested from them. This links into as well that they have returned to face-to-face training, and again, certainly the feedback is that that face-to-face training means that staff are connecting better in terms of wider safeguarding issues. Alongside that, there have been some capacity issues within the safeguarding team, which are now being resolved, and so we're hoping that the risk will lessen within the safeguarding team, but it's something we obviously monitor closely. The other aspect to highlight is our sexual safety training compliance, and that has been reviewed in terms of the whole process. That unfortunately, what happened was that a number of staff were trained at one time, which also meant at the same time, in terms of the initiative, which also meant they all went out of date at the same time, and hence there has been a delay. Additional sessions have been planned for July and August, but the delay in that is they have to be in line with the
notice. So that is being actively managed, and we will obviously keep that under close review. The other aspect to also highlight is the clinically adverse event incidents closing within 30 days continues to deteriorate. I'm sure everybody does understand the pressures within services in terms of resources and capacity. What we have looked at is the majority of those that are not closed within 30 days are the no and low harm. That does not mean that the datix isn't, datix is submitted, it's looked at, it's the next step of the handler closing it down, but that is under constant review. And then the last aspect is the lying and standing blood pressure recording. Again, that has been a challenge within the due to reporting, recording, and also capacity issues within the directorate. They've done an improvement plan. We did within the improvement plan, the target, our target is a trust target of 90%. The national target is 60%, and in line with our move to integrated performance and quality report, which I should have said at the beginning, I apologise. We are going to be reviewing all quality metrics. That's in process at the moment, so that when the integrated performance quality report, which everybody will call with the recommendation from the well-led CQC well-led 14 months ago, and hence why we've still got the quality report at public board today. Holly and I, in terms of mapping this out, we anticipate that we'll be in this position probably for one more public board as they come together more closely through the committees, and look to October board where we'll have a single integrated performance and quality.
Thank you, Rachel. Thank you. Rudolph.
Thank you very much. The training thing does sound like one of these instances where the MOT light system might get slightly less probably numbers.
So you project towards the green light.
Do your training once a year in a sort of MOT light system and be a bit flexible to preserve your anniversary date, that might help. But could I also ask about the post-tranquilization installations, because those numbers look up a little bit.
Yes.
Worryingly low.
Yes, and again, this was raised previously at committee. There has been a deep dive into that, and whilst it is a reporting issue and some are being pulled through system one, so there is work ongoing in terms of improving that.
Mark.
For the complaints and the clinical adverse incidents, each time someone doesn't obtain the target, do they actually put a reason down of why the 30 days or the 60 days or wasn't met? So then it's easier then to blame what may be the cause of the not meeting the targets. Is it purely we didn't have the resource or not? But I think that could aid in analysing why the issues are recurring.
We know from a complaints perspective, we know in terms of the investigating managers, and that's escalated through line management and directorates in terms of reasons, and sometimes investigating managers may well change if somebody cannot meet it by sickness, etc. From an incident reporting, I would have to find that out. I don't think it is recorded as to why. I'm looking at Holly here.
So I think through our performance risk executives with our directorates,
Yes,
at directorate level, that they are understanding, I guess, do we formally capture? No, we don't.
Because it may actually just help,
Yes.
because instead of analysing it, then immediately you get the answer straight away.
Okay. Can I just indulge myself with a question, Rachel, which is about trust policies? We're not where we would want to be, and this is something I do, as you know, feel very strongly about. That we should be at more than 85% being up to date. So how are we going to get much closer to 100% quickly?
From my perspective, Eileen, obviously each executive is responsible for their own areas. Martin coordinates the overall process. From a discussion that we've had recently, it's important that we actually do a review of who the owners of those policies are. And my understanding is that that is in process. So in order to, we've got many policies are not necessarily allocated to the right person, and that piece of work is happening now. Didn't want to add more.
In your custody.
I think this is a key area for us, and I think it's probably one that we'll take outside of this meeting, because I think it's a key performance part of our governance arrangements for well led. So I think it is something that, pardon my narrative at this point, but it's probably a bit clunky, and therefore could do with being refined. There is a couple of options that are being explored at the moment digitally around using AI differently in this space, which is actually rather exciting. It is rather positive, and I know Natalie, Natalie is custodian of a lot of this. I don't want to embarrass Natalie, but she's been working with certainly Richard around the creation of a digital model here, and Jonathan, that will allow this to be much more streamlined. But what we'll do is we will take this back, bring this back, not through board, through committee, in terms of oversight as to where we need to be at 100% with this stuff as close to possible. So, and we need to simplify for our workforce. So when I say clunky, it's just got to be usable, readily accessible, and easy to sign off and agree. So we'll take that as an action.
I say it not because I'm obsessed with bureaucracy, but rather the policies should set the framework for the ways in which we work, and therefore having them up to date, accessible and understood and implemented is absolutely critical. Robert, should we go to you to bring some delight to our lives with the finance report?
The finance report you have in front of you is very much the high level position for month one. Month one, the NHS is not done to the same depth as we do for all other months, because clearly, as you understand, there's a lot of focus on both the month 12 year-end accounts and the 14 reporting, as well as work on making sure that we've set and aligned budgets within each directorate. So a lot of work goes on, and because of that, it's much lighter than you will get in the future. In terms of month one, it's broadly in line with plan, a deficit around about 1.25, 1.35 billion. On two different lines were measured on the top one, not the adjusted, but for clarity. We put both lines in the adjustments there. Capital is next to be ahead of plan. It's minor. It's 140k against 100k. The issue for that is not issue. The reality, of course, is capital plans flow over years. Some of that is continuation of work we were doing in 25-26. You can see that. In terms of improvements in the month, I think we've been enhancing our financial discipline and value for money decision making. We've seen a slight reduction in particularly on non-paid spend, which we are going to manage very much in terms of run rate. To make sure that we continue to do that, to push for that to reduce month by month. There will always be challenges. There are always exceptions that come in and payments that get made in various elements that we need to make sure we manage. In terms of the pay, two aspects just to remember in terms of looking at a very simple run rate. When we do look, not in this paper, but in future papers, month 12 is always an anomaly in terms of pay because the national pension makeup market comes in, so we get a huge contribution to pay. Obviously, always is different in month 12 to what you would see in previous months. And clearly also from April, I think was the pay award of 3% that goes in. So you would naturally see an increase in the like for life pay. However, that's a key area that we need to continue to make sure we make the best use of all of our staffing resource, because you know it's pressured in terms of the staff that we've got, but actually there's much pressure because we have processes that aren't always as effective or as planned as we would like. So we need to make sure we're optimising that sort of work. This year is going on in ensuring that we've got staff supported to be in the right place at the right time. And that helps us in terms of premium payments and excess payments as well, for example. It should be noted, of course, that we have put extra support into a couple of areas. We've been resolving some issues on board, so there's some extra bank resource has been required. And I think at least a couple of our awards while we address those issues. But hopefully, once we've done that, we can then take those back to the right levels. I think that's about it.
Very good, Steve, and then to Mark.
Okay, thanks, Robert. Obviously, early days, month one reporting, but we're good to see that it's only recurrent savings that we've achieved. And certainly welcome the comments in the report about not relying on non-recurrent benefits throughout the coming financial year. Really important comment there in the report. My only question, we've got BMP later in the month. This is a performance committee which will look at the cost improvement plan in a bit more detail, which will be good to see. Is there anything that you can share at the moment in terms of the progress that's being made before we get to that detail at the end of June?
Okay, so from I think there's a lot of good work being put in place in terms of both internal communications, but also in the, should we say, realignment of our project management office, supported by with some professional external support. Why? Because we probably don't have all the skills and capacity in house. I think it's an ongoing challenge for us to really review our processes and policies that perhaps impact on those processes. That's in place of particular areas. There's three key areas that we're focused on. One is making sure we already have vacancy control panels, making sure that we're really focused on non-pay, in particular management, whether that's which is already in place, for example, in our estates facilities, where they look at that every week with our software and hardware support suppliers. Doing the same through the directorates, and I will dip in and out along with my operational director of finance, because it is important that it's the directorates that lead on the controls, because the aim there is actually, of course, that it's owned by managers at the right level. So there's a level of oversight to make sure we've got the right processes, the right grip and control, the right big initial appropriate challenges. We've got those in place. The other two key areas which are really important. One is our staff rostering, where we know we've got challenges. I think we've identified a number of opportunities to improve that, or for staff welfare, staff management, as well as actually an opportunity to optimise, as I said, the resources to make savings. And the other area we're looking at clearly things around our patient access policy and how that either inhibits or impacts on consistent approach to managing patient capture in terms of appointments and scheduling across all of our directorates. And I think it's that area where we have, it's known as the clinical admin review, but it's very much around actually that we've got over the years, directorates, different service teams use systems differently. What we're trying to make sure we do is proof of standardisation. So again, I don't going to see immediate, all of a sudden you'll see a dropping millions of pounds to spend. That's not going to happen. This is about real control on clear processes that allow us then to actually realign and appropriately reduce resource over the next 6 months to a year to 2 years, actually on a continuous improvement innovation space. So not where we want to be, of course, never is, but I think it's moving in the right direction. And I think there's a solid awareness across the organisation that real approach of value for money decision making.
Right, I think Stephen is your partner here on this, so to be brief, and then I'm going to go to Mark.
Thanks very much. So, I mean, really just to encapsulate all of that, Steve, there'll be a formal report coming up to BMP. It will cover, as Robert said, on a lot of detail there, the 4 sort of key delivery pillars around workforce, clinical pathways, that broader sort of admin transformation of obviously states. So you'll see some, reports against that. I mean, I think just the other really quick bit for us is around how we engage the organisation, how we sort of have the conversation, and how we change the culture around this. So again, we've been working with comms colleagues to make sure that we've got a clear narrative to go across the organisation. We've got certain engagement, and obviously we've been using like our management HUD on that with Steve's, and obviously comms going out as well. And we'll continue to do that. And at the same time, we've been driving a message actually around don't wait for us. We give you permission to make some of those changes as well and to drive levels of innovation and ownership as well at a sort of a war team level, which I think is really, really important here. So there is that sort of overarching structure. We've got some support in. There is the engine room. There is that sort of drive there, but we're also encouraging ownership across the organisation at a lower level as well. I think that's really important to recognise that.
And Mark.
Robert, just on the age debt summary, again, it may come up quite, I think I can't remember. But the 261 days debt of 1.5 million, that's an awful long time. Is it a contractual dispute or is it?
There are a number of bits. I will, if you forgive me, I'll bring more detail to the business performance committee. There are 4 key areas within the 361. Clearly, not clearly, there are historically been issues around staff overpayments. Typically, when you have staff overpayments, we then agree a schedule of repayment, and that can take some time. So of that 1.5, something like 350,000 is actually related to staff repayments that are required. That's not untypical, by the way, in organisations, but it is something that we have to really, this is again about basics. We can control the managers, making sure when a member of staff is leaving that they're properly put into the ESR system with a date of leaving, and therefore no risk of overpayments, but it's happened. So we need to address those ones. There are 3 others. We've got some challenges, I think, with long-standing contracts with a number of our local trusts. One of them's about 300 and 275k. I think that might be over a couple of trusts. I'm getting into that one. Also similar with the ICB. Again, that's about 400,000. We've got one major one with an outstanding, from what I understand. But I've asked the team to pull all that out, and we actually need to make sure we're resolving that.
There's also, if you're not going to recover it, then of course you have to provide it.
It may already be. There will be elements of that. There will be an element of debt provision that doesn't show up here. It's important to show the debts, as you know yourself from the audit committee. But, so I've got that on the list to actually this month. We also agree balances of agreement between each other. We actually, I don't think I need to review that. I wasn't. Forgive me, I've forgotten what happened at the last audit committee. But where we have the balances, is that agreed? There's something that is it a big difference or not? So is there an agreement of balances where we do have a major dispute? But I need to look into that further. So thank you.
Thank you.
Steve, and then we must move on.
Thank you, Chair. I think there's just a point I was going to raise. Mark, thank you for raising that. I was going to invite Robert to talk about that because there are big numbers on there, and I know that's in hand. I think, Steve, the point that you made is incredibly helpful in terms of what plans do we have in place as a trust to make sure that we've got a sustainable future. It's a moot point when I say that isn't just about the end of the year, because it's about the long-term future for the trust. However, the end of the year is also super important. A question that I know has been asked, legitimately asked, and rightly so, is how do we assess the impact of the changes that we're likely to make? What programme architecture do we have in place to assess the safety of the changes, whether we address changes to the service model or whether we do that through either transformation or efficiency? And I know governors have asked this question collectively as well, Chair, and I think it's really important to say that every scheme through what we would call the engine room is being clinically led. There is oversight associated with these. There is the right level of kick, challenge and conform when it comes to things that we have 4 areas of focus. One is, and this is really important, one is around discipline, having the right things. So Robert described grip and control, having the right discipline in place and the right governance around non-pay spend is really important. And although every organisation would say that, it's also really important to reinforce that. The second is waste, where we do things that we shouldn't be doing it, or we do it twice and we don't need to. That's equally important. The third is transformation, as in modifying something against best practice, national best practice, evidence-based practice, and looking to modernise in that space for the betterment of patient outcomes. And then the fourth is that word efficiency, where we can do things where we don't have to expend as much. All of those are assessed against those frameworks. So I think it's really important to say that as these programmes of work get traction, you will see them next door in the engine room. You'll hear about the narrative that we're using, but they are being tested before they're implemented. I think it's just a really important point to say.
Okay. Thank you for that. I'm assuming that our next public board meeting will be talking with much more evidence behind us around the progress we're making on the savings targets that we have for this year. So I'm looking at yourself, Steve, and Robert on that to anticipate that we'll get much more detail. Thank you. So can we then move into the people and culture section of the meeting? And Pri, I'm going to go to you for the people and culture subcommittee report.
Thank you, Eileen. I will take the paper as read. It relates to the meeting that was held in April. There are a couple of points I'd like to pick out. We have been discussing this over an extended period of time, but there are still challenges surrounding the physical intervention training for staff. One of the things that the committee asked to clarify was whether the sort of compliance rate that's reported to us includes or excludes those who themselves physically aren't able to take part in that training. So that will be clarified, but we are still, even if those are excluded, I think that we're still behind where we need to be. And it is important because it places extra pressure on staff and puts, because it's an additional risk for trust. So it's something that we will continue to follow up on. The next point I wanted to raise was about the new payroll system, which does follow on from the point that Robert made. We do want to thank a number of people of significant time and effort into introducing that system. I think it's one of those things, if nobody says anything, then it's generally going well. But obviously, I believe it's, we're getting better reporting and better data and better service. So as a committee, that's good for us to hear. Also, the new occupational health provider is fully rolled out from this week. So we'll be working slightly differently and hoping to see better results and better management in terms of what the committee sees and how staff are experienced that. Sickness continues to be a challenge, and that's something that again as a committee will continue to monitor. We're aware that often we're in line with national figures, but that's still something that we need to think about as a trust. A couple of things that we do raise frequently, the appraisal compliance levels are still below where we'd expect them to be. In particular, in the corporate area, it has improved, but we're still conscious that we're below where we'd expect that to be. PCREF, so that's the Patient and Carer Race Policy Framework. That's the framework that mental health trusts have to work under. A lot was reported back to us, but there are still concerns, still things that we want to see improve. I would like to say thank you to the staff networks who do contribute to the work in this area, but we are conscious that in terms of health inequities, there is more. One positive, shaping our future together, a lot of work has been done by the learning and organisation development team, but one of the changes they have made is to acknowledge that we have workers working a lot of different patterns, so they're trying to flex what they deliver and how they deliver it to take account of that, which we would like to recognise. The last couple of points, under well-led, there are a couple of areas that we continue to focus on. One is the physical intervention training that I just mentioned, and the other is freedom to speak up, where we are still as a trust experiencing challenges that we need to recognise in terms of making sure that people feel they can speak up and that we're able to report and act on what comes through there. And the last point, policies, which has already been mentioned, we are still not where we need to be. I appreciate the answers that have been given, and I'll stop there.
Just a question. Well, it's not really a question, Pri. I think it's on the back of we recognise there's still a lot to do. I think, Chair, you mentioned people as one of those top three things that we as a trust shouldn't lose sight of as we work through all of the other stuff to do with the money and everything else. So one of the things that I think the CQC identified from a well-led perspective was a need for us to really strengthen our oversight around the people aspects and our cultural aspects. So just to alert the board for assurance that we are taking steps to bolster that, certainly over the next 12 months leading into maybe a different way of working, with a key area of the individuals that will support and bolster this, focusing on the things that you've just very mentioned. So just wanted to give that assurance.
Mike.
think Holly might be coming in.
Please.
I was only going to just mention that this week we've had our performance risk executives meeting with all of the directorates, and actually adults shared some really positive work around the physical interventions. So I just wanted to sort of offer some assurance in terms of that work is definitely progressing. The Associate Director of Nursing was really positive about where they're going to get to in that space.
Mike.
Yes, sorry, Chair. It was really just to highlight the staff survey and the 3 priorities that you've identified. And from a quality point of view, having staff who feel able to speak up or raise concerns is very important. And one of the 3 priorities is just that. We don't know what's happening unless staff tell us what's happening. And so I guess what I'm doing is appreciating the fact that you spotted that and there's an overlap between quality and people and culture, and particularly the staff survey. So thank you.
Actually, I did have one more point that I didn't cover on my list, which was about the staff survey, and I'm sure Stephen will mention it as well. We are conscious that we have, a large workforce and a lot of good work is done. Not everyone completes the survey, so we're very conscious of that as well. I think for us, it's just finding that balance between we want to see that issues are raised and recognised and dealt with, but also that we are able to recognise and reward and thank all of the good work that's also done. So thank you.
Okay, that's a nice segue to you, Stephen, for your report, please.
Thank you very much, Chair. So first of all, actually, before I do my report, I think it's just to recognise it is Pride Month. And so we do need to just recognise that. We've got a number of events, drop-in sessions and that sort of thing. So I think that's very important just to put that on record. My funding has been slightly stolen in a couple of areas. So we've spoken about doctors and various bits. So just to recognise, we say thank you for everybody for the pre-planning around doctors. We're currently going through that again. And the report does detail out, obviously, the BMA have gone out around balloting both our consultants and SAS doctors as well. And I think that closes in, and I'm looking at Catherine or Kathy here, but I think that closes in June, towards the end of June, actually. It's quite a long ballot period. So again, we'll need to just watch that. And then just a couple of other issues just want to raise out of my report is bank and agency use. We have seen, and Robert's already alluded to this, we've already seen a slight increase on our break glass for a particular clinical area. I think it's really appropriate. We recognise, obviously, that there are challenges and we do need to go down in bank and agency use, be it both sort of nursing and medical, but also we need to make sure they've got the right sort of quality and safety and the right staffing levels. So in a particular clinical area, we did have to put some additional staff in, certainly during March. And then just a couple of other really key areas just to draw out is around sort of we've seen employment cases reduce as we see sickness reduce, and we continue to see it reduce down actually in April and into May. Recognising this is March data, we are seeing a reduction in the number of cases, which again I think is really, really positive. And it's a piece of sort of oversight that we do sort of pick up in quite detail at People and Culture Committee. And then finally, just follow on from it's a really big thank you actually to the HR team for the work they did on the procurement around the new sort of occupational health and a new payroll contractor. And actually just picking up some of that tech for a moment, you don't have to have a separate login, you can use a CPFT login to log into those. So again, that just sort of helps staff with many different logins as well. And actually I've been using the occupational health provider and I got a report back in less than a week, which actually was incredibly good and incredibly positive. So may that continue, and I'm going to stop there and answer any questions.
Right.
Yeah, it's about the resident doctors. So obviously we're concerned that they are balancing again on a strike, but there are things that we're doing, I think, around the 10-point plan, which is to improve the experience of doctors in training. I just wondered if there's anything we can say about that and how we're doing with regards to that, because the pay is nationally determined, but the 10-point plan is about what we can do to improve, food when they're on call, things like that. I just wondered if there were any points.
So I suppose what I would say is we're doing very well on that. So there's something like, well, certainly over 90% compliant, and the issues that are outstanding are largely to do with a particular policy which we are working on. The latest sort of development was they had a tasting for food at night time, so the provision of food at night time is something that estates have been helping with. So I haven't heard how that went, but I presume it went well. So I think they're generally quite happy.
Thank you.
Chair, I think it's worthy to note that the officers that are responsible for our resident doctors have direct access to the Chief Medical Officer, the executive team, the Chief Executive, in terms of oversight from this team, in terms of the importance that we put on that 10-point plan, Mike. And I think that has meant quite a lot to them, because we see this as something that's really real for them in working conditions and supporting them. So certainly the narrative I've had back from them has been one of appreciation.
Okay, I think probably a question is important to ask. One of our partner trusts has recently discussed in its own board meeting that it is seeking to offer an exit from the organisation for several hundred people. And clearly our staff would have seen that and wondered what we're doing. I know that part of our strategy is to be very robust on vacancy control. I would say if you look at our vacancies, though, we're still advertising roles in significant numbers. So I suppose, Stephen, looking to you and Steve, to just comment on our strategy. We won't discuss other people's strategies, but actually how effective are our controls on staffing costs?
You'd like me to go first of all. So, I mean, I think there's a number of sort of things there, Eileen. I think first of all, we talk quite a bit here and then subcommittees around the vacancy control process. And again, there is sort of robust check and challenge in that process for vacancies going through, or not as the case may be. They're supported by quality and equality impact assessments as well, and we've already spoken briefly about that. And actually, we do bear down on that, and we do sort of pause or stop processes going through. And obviously, from that sort of external sort of optics, we have had some feedback on that process as well to date, and they say it is robust, but that you may want to look at other issues as well. And again, Pri and I did the staff induction this week, and we had something like 27 people, which is our lowest staff induction we've seen actually in the organisation, which I do think it reflects down some of that check and challenge that we've put into the processes around staffing. On the other hand, when we were doing that check-in with people, that the majority, if not all, were clinical and appropriate clinical for eating disorders, community health teams, etc., district nurses as well, where we know we've got some vacancy challenges. So you've got the right people coming into the organisation. We will continue to do that check and challenge. We will continue to listen to some of the feedback we get as well around that process in order to drive that. And then coming back to your next point around, some of the challenge we've seen last year around sort of, potential for redundancies, potential for mask schemes. What we've done in CPFT, we've tried to use vacancies. We've tried to redeploy staff, recognising the challenge there for people, and also recognising the skills we've got in the organisation, that we will redeploy people. In fact, we've just been part of a sort of a broader survey around mask schemes. And the feedback around mask schemes nationally, that's mutually got to pay for. Agreed resignation schemes. Actually, what they seem to do a lot of, you'll have organisations 5,000 to 6,000 where actually you get about 100 people. And what they're saying is they're getting less and less people going for mask schemes. And actually, where 100 people have gone for them, they're actually getting literally a handful coming forward. So they're not as successful as they were. And I think people recognise some of the challenge in that. And then, of course, you take people up the foot of a hill and promise them, then you don't give. So you have an actual impact on the culture of the organisation. Going back to your point, we very much will continue to manage that workforce through that vacancy process and also through that sort of potential redeployment process. We did a number of mechanisms last year to support that, and we will continue to do that. So at the moment, we're not ruling out redundancies in CPFT, but what we are saying is that we will look to redeploy staff first of all, and ensure where we need to sort of pause recruitment into certain posts, we will do that first of all.
So I think the message, Chair, to our workforce or anybody that was listening is that the organisation needs to be the right shape and then the right size. And the route that we'll go through to get there will be to make sure that we manage the integrity of our organisation and our services. We will recruit where we've got areas where we feel clinically that we are diluted, and therefore we will not tolerate a change in safety. However, where we do have opportunities to redesign, we will make sure that we offer our workforce as much as possible the opportunity to align themselves to a different role, to retain their experience in the organisation and their commitment to the trust. In the event that we cannot do that, then we will target and work with those teams individually rather than blanket the organisation. I think that's the most effective route. However, we will land on a space where we need to be the right shape and the right size, and that will come forward with some of the review that you wanted to pick up at the next board around some of our improvement areas.
Jackie, do you want to come in before we move ourselves along?
I think Steve G has just touched on a point that I was going to make in terms of vacancy controls and other tactical solutions are okay. But where are we thinking about the connecting of and it's my favourite subject, workforce planning into the SIP programme? Because we should possibly consider what capabilities we need as part of the redesign we're doing and start forecasting those in now, so we're not meeting bump sticks on the way.
Yes, yes. 100%. Yes.
Do you want to add to that?
No, I agree with Jackie. Part of that transformation work is making sure you've got the right skill set, you've got the right staff, you've got the right skill mix around a sort of redesign organisation. What we've not spoken about today is that sort of that broader target clinical operating model work that we started we're working through for the organisation. Obviously, when we put on medium-term planning, we did have to be quite clear around some of that sort of workforce. When we put a workforce plan in, so you can see in that where there are some of the changes that we're proposing going forwards. But actually, there's flex against that plan as well as we develop these and sort of work both clinically and operationally across the organisation as well, and then to take EQIs and QIAs so that we will reshape and remodel it as we get to that end state.
Let's just try not to use too many acronyms for people. The NHS is their fuel, so let's just try and remember that it's not everybody's fuel. Okay, we're going to move on to a report on our survey report for 2025. The sequencing of this is obviously the survey took place last year. We're about to move into the surveying of the 2026 experience. For those governors who are with us, many of you had the opportunity for a presentation on this with us in one of the joint forums that we held. So to a large extent, many of you with us today, you will have had the opportunity to participate in conversations around this. But Stephen, let's go to you.
Thank you very much, Chair. So I'll take the paper as read, and I'm not going to go through the detail of the paper. You know, as Eileen has said, the survey came out in March. It took place last year, end of September through to sort of November, and we are actually currently planning for 26-27 survey. I think the really key point is that one, we increased our completion rates, but also we recognise there is some pretty challenging information in the survey, and I think it's a real sort of call to arms around the organisation and thinking about how we take forward that sort of that cultural work and how we take forward a number of those key areas. So since we've got the survey, we've had a board development session, we've had a council of governors session to discuss this, and actually we picked it up twice in the People Culture Committee as well. So I think we've given it plenty of opportunity to sort of have some pretty detailed conversations. And then point 5 in the actual paper talks very much around key priority areas and focus for 26-27. And again, it gives you that around sort of developing and support of our staff. It gives you something around the psychological safety and raising concerns, which obviously Preet mentioned earlier on. And then there's something around that communication and engagement across all and sort of reward and recognition programme. And then just a couple of other bits to flow in. Obviously, we are developing that sort of that cultural sort of cultural work, and again we're sort of focusing on developing our trust leadership team, and we've got our sort of potential shadow board starting soon as well. So there are a number of initiatives around this, and finally we are working with directorates as well for sort of directorate specific interventions And again, some of those may be working with a particular community team or a particular ward, and it is focused on a particular area. We can go down to that level of detail in the staff survey, that level of granularity. I'll stop there and answer any questions.
Steve.
I think, sorry, to thank you, that's super useful. I'm going to be slightly contentious here. I think staff surveys are a useful temperature check in organisations. Our pulse survey, however, is super useful because our pulse survey's contribution to insight in the organisation is different to the staff survey. So the staff survey is a nationally prescribed thing. People are have always been somewhat nervous about this process. And by design, most of the staff who speak up in this area have something to say, and I think that's really important. However, our pulse survey does give us real rich insight into how our bit of the NHS is operating. I think when I speak to staff and when the team speak to staff, there are some overriding statements come out of here, all of which I am delighted are in train. So one of those is that word culture again. We talked about that. Some of the stuff that gets in the way of people feeling, we talk about what does culture mean, somebody feeling supported, feeling valued and feeling respected in the event that they have a concern, a challenge or a problem. And in this case, when you talk about the presentation this morning, that's part of a redesign of our culture, about giving staff the confidence that we're backing them and we're supporting them when something isn't quite right. The other area is being an anti-racist organisation. Just call that word out for a second, even if it's an uncomfortable word. Racism in organisations is something that we need to tackle and will continue to tackle. And the PCREF stuff that Bree's just mentioned is something that we are taking incredibly seriously. And I am really pleased to see it's starting to get some traction. We're not there yet, but that's a big indicator into, if you're a member of staff and work for CPFT, what can you expect? Well, you should have an organisation that lives its values, that respects you and your diversity, that doesn't discriminate against you and provides you with opportunities for your development. If those four things are not in place, then our staff have every right to challenge us. But I'm really pleased to see that they are moving in that direction. But I would urge us, I think through people and culture, Stephen, with your support, is to start unpacking the pulse survey a little bit more. And the point I made about strengthening and bolstering our people functions in this space, it picking up a lot of the stuff in here. And Chair, this is the contentious bit. Sometimes when you benchmark this nationally, you kind of say, well, we're not bad, are we? I don't mean to sound crass, I don't care. Because anything in here in this organisation that is either going down or in the wrong direction is our responsibility to address. It's not to neutralise it by saying it's in the pack or it isn't. So just something I wanted just to raise. Thank you for picking it up.
Karen and then Mark.
I think my question is, looking at it through the staff lens, we've got the pulse survey, we've got the national survey. How will the staff know that difference has been made? Because we're doing a lot of stuff, but how will the staff know and feel something is different? They've completed the survey. We've heard that they get fed up constantly doing stuff and seeing no outcome. What outcomes do we expect to see, and how will the staff see and recognise?
So I think that's a really, really good question. So I go back to the point around, there is something around some of the strategic work we're doing that we've already spoken about, around sort of leadership development and the sort of shadow board. We're just starting the reverse mentoring, for example. Again, we're encouraging that. So people will actively see that, they'll feel that will help shape. And again, some of the work we spoke around the Operation Cavell, that will fit into the culture and I think into the staff so as well. So there's a lot going on. I spent some time actually on the reception at Cavell a couple of weeks ago. If I'm there and how do I feel, then actually that's where those individual action plans come in. That's where you get the richness of that data and you actually sort of, feel as if I've got a particular issue in my team that I've raised through the staff survey. Now, it's not, you can't apportion it to an individual because you can only go down to that level of 10 people, but it does make it real when you start doing some of those changes within the teams. So again, that work is ongoing. What we've not done, we've not changed the whole of the action planning, because one of the feedback we get from people in culture is try and keep this simple, try and keep a set of clear priorities, try and align it to some of those strategic works you're doing. But again, that's that sort of local level. And I think that will have a direct impact, Karen. I think that's really, really important. Just going back to Steve's point around the pulse survey, that gives us a really rich set of data that we feed into some of the work we're doing around freedom to speak up. We are one of the highest return rates. Actually, we were the highest last year, actually, around the pulse survey. And it does give us that rich data. And how we use that, again, is we use that to help shape some of our policies, some of our processes. We change the questions there as well. And again, I think what we do need to do slightly better is embrace that, but also sort of sell that and show that we're doing that a bit more in a bit more of an open way, Karen.
And sorry to break protocol, but Karen, you're absolutely right. Not organisations tend to do the "you said, we heard." I just want to add a second one on the end of that that says "and then we did," and we need to communicate that better because I don't think we communicate that as well as we could.
Mark, did you want to come in then, Mike, after that?
Wait, what on the peak, I think, just to take the observation, it's the patient carer. So it's not just about staff. And the work that Anna Took does this in terms of, and the carers board, which Karen, so I think it needs to be considered in both, and both committees look at this, but it's about the fact that patients and carers from racialised communities don't get the same outcomes as others. And so in my head, I hope it's helpful, we've got those two fronts opening up with regards to these issues, and the patient and carer bit is a bit
Just on the staff survey part, have we reached out to other trusts? I know it's difficult to know who are the ones at the top, but what things maybe they are doing which either encourages more people to participate, or the individual factors of are they doing some initiative which we could learn from in order to then improve our scores kind of on there. But at least then you don't try and reinvent the wheel, you're just plagiarising what others may have done and which kind of worked.
Again, I think that's a really good suggestion, Mark. So we got our survey company to come in and meet with our staff for our people strategy delivery group. So that's all the directorates, that's professions, that sort of thing. And they were giving us that feedback around who's doing what where within your sort of cohort. And they represent about 27 organisations that use that particular company. So that's work in progress. Then there is also a national network that Rachel King links in as well. I mean, there's some interesting feedback, not for now, around some of the broader challenges that we're all facing around culture and some societal issues, which I think is really quite interesting, and how it's sort of shaping up some of the challenge within the culture of these organisations. But that's something that will pick people in culture. Yes.
Thank you. Going to go to Jackie.
Just very quickly, I guess we're almost getting into the next this year's survey timeline. I was just wondering what considerations have been given in terms of how we start joining the communication that we did into preparation of we are about to do another survey.
So we have Staff Survey Connect, which we send out across the organisation. So we use that as a bit of a vehicle to sort of close that, square that, close that loop, etc. The other thing we are looking at, and again, it's something we discussed at People and Culture, is the engagement. Because what you do see is an interesting shift in some of the data, depending on the size of the cohort who respond. And that's one of the interesting dynamics around the pulse survey as well, because we get a much greater pulse survey response than we do a staff survey. So again, we're just thinking about how can we do that slightly differently? And is this as basic as literally just going around walls, either with paper-based sort of, or whether it's actually going around with computers as well. So, but we are doing that Staff Survey Connect as well.
I'm really sorry, I know we want to move on, Jackie, but there's a moot point here. Again, for all staff that may watch this back or listen to this, I just want to say thank you for filling this in, because we had an increased number of people wanting to talk to us, which is brilliant. And we spent a lot of time asking the workforce, please give us your views. There's a however bit, shouldn't need to wait once a year to do this. So staff should be able to express those views every single day on their shifts with their line managers and feel that they get heard, they listen, and there's some action. The organisation is pretty slow when it comes to raising those issues and then going back. And there is a huge amount of area here for improvement. So we'll use it as a proxy, but we shouldn't be using it directly. We should be doing this every single day. It's an obvious statement to make, but that'll be our change in culture.
And just for clarification, a pulse survey, which we do a number through the year, tend to be smaller, more targeted, much less time consuming to fill in, and as I say, targeted and focused on particular areas of response, and possibly that is why we can get better responses to those, I think, anyway, Stephen, but don't want to delay too much unless I'm completely wrong.
No. Just really important because it's national, so it is actually using some of the staff survey questions. So there is now a complete alignment, and then we have to feed it up. And as you say, I mean, it gives us the opportunity as well to slightly ask additional questions over and above. We do it on a course basis, so it's really.
Thank you. I must move us on. Without further ado, Steve Cox, I'm going to you for the business and performance assurance report, if that's okay.
I'm going to chair the last meeting.
Oh, of course you did. I do apologise. I forgot we had some musical chairs.
Thank you, Eileen. So just to take you a little bit back in time, because this report was in April, or the committee was in April, and we had a report on month 12. Obviously, we've now just heard about month 1, and obviously subject to audit, the deficit is clearly stated in the report. We had quite a long conversation about the link between our outturn and the cost improvement programme, and we were keen as a committee to be assured and to learn from 25-26 cost improvement in terms of how we can apply that learning to the 26-27 cost improvement. So looking forward to the next BNP committee, where we will see early sight of the IP for 26-27. We spent quite some time, actually, before I move on, there was some advice from into the room about actually, in terms of our saving commitments for this year, we should aim for looking for more than we actually need, which will give us some options during the course of the year and some flexibility. We had quite a lot of individual items on our digital platforms. We've already talked in this committee meeting about the ambient voice technology, but the overriding comment back into the committee was along the lines of it would be really great to see the final or the first or final draft of the digital strategy into the next BNP meeting. That kind of brings all of those digital aspirations that we have together, brings them all together, and so we can then discuss those in the round. We had quite a thorough conversation around service visits. There were 16 outstanding actions for service visits assigned to the BNP, and we felt that actually there is still this need to ensure that there's a substantial feedback loop. Those questions raised by colleagues that were actually closed, so they actually understood what had happened to them. And it goes back to the conversations we've just been having in this meeting today in terms of you said we did and we have done. So I think that's another cultural piece that we need to keep an eye on in terms of those staff visits. We had a line-by-line discussion on the operating risk register, which was really helpful. It cleared some of those actions down, and we thought that the principle around actually only removing a risk when a target had been achieved and not removing it beforehand, that was really a productive conversation. We welcomed a report, although it wasn't for us to approve just the actual process of the financials around it, but we did and were curious around the supporting wounded veterans, which Kathy Walsh brought forward to the meeting as a research project, which we thought was really exciting and very, very worthwhile. Holly provided us with assurance in terms of cyber security, which was interesting really, and caveated by the fact that actually in the current internal and external environments that we live in at the moment, there's always need for I was going to discuss Operation Cavell, but we've had a fantastic report and presentation this morning on that piece of work, and I will leave it there. Thank you.
Any questions on this report? Steve?
Just one, Chair, on 2.5, Jackie. Thank you for raising that. Given the assurance level here is limited plus, and I make a recommendation, Chair, that we take this one outside and look at this as a bit of a deep dive as a collective board in terms of the mechanism, process, and feedback.
And just to play into that, Steve, Natalie did provide us with an update that there was some work being done in the background in terms of the service visit process.
Yeah, I think we collectively just need to have a look at this, of its effectiveness and its reach, and then come back together because from my perspective, I see these which are really good, they're different. And so with the variability that we've got, the expectation of staff, dependent on who visits and how that gets fed back, is different, and it would really do with a good standardisation conversation.
I would observe, as I observed somewhere else yesterday, that feedback is key. Our staff consistently give us feedback. We need to appreciate that gift and do something with it to continue the theme of service visits are another mechanism by which they feel in a more personal environment they can provide feedback on things which are getting in the way. So hopeful that we can do more to move from the limited tolerance there. If we could move then, Holly.
Sorry, 2 seconds.
Okay, we've got something going on outside which we have to deal with. So maybe I could.
I'm just
Right, we're moving people around. Holly, the integrated performance and quality report for you, please.
Yeah, thank you. So this report, which has been through both the health safety and patient experience and feedback committee, reflects improving maturity, performance framework with clearer targets, stronger oversight, and better visibility of medium-term risks linked to the delivery of the medium-term plan. Overall, it shows that while many indicators remain stable or have improved, there are important improvement. In terms of highlights to alert or to, whilst we've seen huge improvements both and length of stay, our current performance remains above internal thresholds around length of stay, so we continue to work with our clinical and operational colleagues, but actually need to highlight the huge improvements in our inappropriate out-of-area placements as a result of the change of model and patient boards, and thanks to clinical and operational colleagues for leading that work. In terms of access and waiting times, we know that these are huge pathways around children and young accessing mental health services, and also our ADHD and autism pathways. The trajectories for improvement are challenging, but we continue to focus on that. And just to highlight, which a number of other colleagues have touched upon today, is the productivity and transformation delivery. So we know that the gap between where we want to be and our current operational capacity presents a medium-term risk. But again, through the engineering of our PMO capacity, we are addressing that. Board has advised that portion of our metrics do remain off target, but actually are stable, so not deteriorating. And that reflects sort of sustained operational pressure rather than short-term performance issues. We know that we've got challenges around productivity, access growth, and activity assumptions, and that's dependent on future service transformation and also our workforce capacity. So really trying to draw out that interdependency between the transformation and efficiency work that we need to do, but also making sure that that addresses some of our performance challenges. In terms of providing insurance, there is strong evidence of sustained and stable performance, with the majority of our indicators holding position over time, although we do recognise that some areas are not yet meeting the agreed target, being the national agreed. And there are some demonstrable examples of real improvement, noticeably within crisis response, where we've demonstrated that focused operations work, improved performance intelligence and clear accountability have delivered sustained gains. I would just like to highlight the acknowledgement we received from regional NHS England colleagues for the progress that they'd seen us make in addressing 52 complaints, and also the open and transparent management of our more challenged pathways. And then people will have seen that we did include in this particular paper an update around the NHS oversight framework. So that was our Q3 update. And just as a reminder, the oversight framework is the NHS system used to assess and monitor the performance of NHS trusts, and it promotes improvement and ensures accountability, and then segments organisations into tiers based on performance. And what I would like to highlight is that in all of the national oversight framework key performance indicators, from Q1 to Q3, we've either improved or remained stable. That's with the exception of our finance metrics. So we know that the National Oversight Framework has a financial override. If that financial override wasn't in place, or our finances were in a different position, we would have moved from NOF segmentation 3 up to NOF segmentation 2. And that's thanks to all of our clinical and operational teams' work. Happy to take it.
You're going to go to Steve and then to Mark.
Thanks. I think just on the NOF, great to see the progress that's being made. On the financial override, at what point can we demonstrate that if we were not in financial deficit, when does that get noted and recorded? At the end of the year, or can it be during the year as the profiling and spend progresses?
No, so because we're expecting all results imminently. We're hoping to get them this week, actually, if not this week, next week. And we know that the financial override will remain in position for posted a deficit. In terms of starting from April Q1, there is a slight challenge in that the 26-27 National Oversight Framework KPIs still haven't been released. So we've had an indication of some changes, and actually from a mental health and community provider perspective, we would welcome them. They're slightly increased metrics, and actually we think have an improved focus on the areas that we are concerned about and therefore feel should be being monitored. Does that mean that actually for April and May we won't be measured on those metrics? No. So when the results come out for Q1, despite the fact that for the first 2 months of the quarter we don't know what the metrics are, we will be measured on our performance. What we have been doing is based on the intelligence that we've got, and early sort of indications of what those metrics are going to be. We've already been monitoring our progress against those, and have been highlighting the areas that we would be concerned of and working with those teams to try and make sure that we're in as best position as we can be without absolutely knowing. But the financial oversight will reset from the beginning of April, but they will obviously look at the first quarter. So if we're not where we need to be in terms of our plan, a financial override still
Right.
I think so. It's if we're on plan at the end of Q1, does that if we're on site?
Yes, it does, yes,
So
yes.
the plan's important.
yes.
There may be a but.
Yeah, there is a slight but in the fact that a lot of the leadership community is challenging this because the difference between the NOF targets and the financial plan is one's adherence to and forecasting planning metrics or actuals. So at the beginning of the year, everybody will be forecasting on plan, which is the bit where I think there's a challenge back as well. You wouldn't not be forecasting on plan unless you've had to reset things. So I think there's a question mark hovering over the top of that. I think the very important point for this trust, though, is when you see this table and this significant improvement from Q1 to Q3 and into Q4, Holly, I just want to make the point that there's been a disproportionate amount of energy put into improving this. But where you see a couple of percents move, which look good, we're talking about thousands of cases of individuals, hundreds of interactions. And I think it's not just a modification of a teeny percentage. There are so many interactions that make up that movement of 1 or 2%, that this is direct improvement of patient outcomes and access. I think we should be really proud of that. The override is something that we know that it's in our priorities to manage, but the stuff I'm really chuffed about is the fact that we're operating into, apart from that, we should be pushing into 2 and then into 1, because that's where the best outcomes sit. But the trajectory at the moment is looking positive, no pressure on it.
All right, I'm going to go to Mark and then to Mike.
And definitely positive from the NOF side. And I know from other trusts that frankly, they don't want you to reforecast. They want you to keep on saying that you're going to meet your plan until month 9 or 10, which again, trying to get it re-baseline then doesn't necessarily work. But behind the scenes, we need to go the likelihood of reaching that. Just looking on the domain level performance summary and exception reports, quite a few of them, it says we're unlikely to reach the target. The question is more, is it we have to wait for this various transformation work to be done to be able to move from being unlikely to likely, or are there actions now which we can do which we haven't done before, which changes that likelihood rated?
I think it's a mixture of the two, if I'm honest, Mark. I think some of these, so for example, think about our waiting times associated with ADHD and autism. That if we don't do something really significant to change that pathway, we are not going to meet the accepted standards. I think there are other things, and I guess the example I would give is our length of stay over 60 days, patients with a length of stay over 60 days. There are absolutely actions that we can and are taking currently to change how we are flagging those patients, how we are doing some sort of early identification of patients who may well reach 60-day plus, how we are then deciding actually, because some of our patients clinically require that length of stay, some of our patients don't, and obviously it's that category of those who don't require a length of stay, but it's due to social care, housing, etc. There are different ways that we can engage, etc. And adults are doing a huge amount of work. So one of the things we've talked about doing is a multi-agency discharge event. Actually, that isn't something that this organisation has done before. Both of our local authorities are really keen to support. So currently, adults are working with local authority colleagues so that we can do that. So it's a mixture of the two. Some large-scale transformation, others there are definitely actions, and it sort of comes back to a bit of clip and control, back to basics of good waiting list management.
Thank you.
Mike.
Yeah, it was on length of stay actually, which is one of the things that is identified as unlikely to be met. It's just a very particular point, but it did sort of leap out at me when I read it, which was the root cause increase of the length of stay in February is the discharge to out of area registered patients. So these aren't taking. Does that mean we're taking?
No, so these are our patients that we've placed out of
However, their length of stay was, one was 69 weeks and the other was 97 weeks. And it strikes me that interpreting the data, we need to be careful in that two patients can significantly affect the LOS figure. And then the second question was around the NAV model. Is that having an impact on the bulk of patients rather than two patients having a disproportionate effect on the average? I guess.
Yes. So I think there are several points there. I think the first is there is a very clear national way of measuring length of stay. So actually, what that does mean is that when you have very long stays, actually one of those going can really skew the data. So it's really important that you both look at the sort of overall length of stay, but one of the things, again, we're talking about what you will see in future iterations of the integrated performance and quality report is the average length of stay, because that gives you a much better sense of what are most people's length of stay, because you then get rid of those extremes. But in terms of how we monitor, it is very nationally mandated. And it does mean that actually those very length really skew the data. So having that detail is really important. The new model across our inpatient wards is having a real impact in terms of inappropriate out of area placement. So we are consistently in the very low single figures. But I guess what I see every single day. So I have to approve all of out of area, inappropriate out of area placements. I will get sort of emails to messages sort of saying this is the situation. Could you give us approval to look? And then within sort of 40 minutes, coming back, not needed. We've actually met with clinicians. We're going to create it on this board, etc. So really engagement, but hugely driven by our clinical operational teams on the ground.
Very helpful. It does raise a question in my mind, though, if we don't want to have out of area treatments. I'm not sure what control we can have over their length of stay because they're not in our wards.
So I think there are the two patients that skew the data in terms of those two very long lengths of stay were patients that were in our appropriate out of area placement category. So they were both locked rehab. You would expect them to have a very long length of stay. And we do contact, so we have both clinical and operational oversight of patients placed out of area. We will put some challenge in if we think that actually patients aren't progressing in the way that we would want them to. And indeed, some of our clinicians will go to review the care being received, etc., and offer advice, because obviously we're trying to pull patients back into our community teams as soon as appropriate.
Devolving safety and quality issues as well to another provider. I've explored that enough. Thank you.
All right, can I just ask everyone in the room to just keep projecting towards the green lights and just make sure you don't have your hand across your mouth or anything at all that could interfere with good diction that can get through to people who are on screen trying to listen. Okay, lots in there, Holly. I probably feel the need to observe we can't be the only trust that has appropriate and lengthy out of area placements. Therefore, there is even more in our gift to get our length of stay closer to national average. So we must do that. We're grateful for the work that can undertake that.
Can I add our current? Because I guess that's a good news. At the moment, our current length of stay across our inpatient ward, 35 days. People will remember that at the beginning of this journey, we were hoping to get to 42 days and struggling. So I think I would like to recognise the great work that done.
I think that's absolutely fabulous. So thank you for sharing that. I'm going to come back to you, Jackie. for the update on the head to toe report.
Thank you. So always a pleasure to chair the charity board. And although we had some outturn figures for year end from the financial officer, they are subject to audit, but on the surface, it looks like Hannah and the team have worked really well, and with 391,000 in terms of income. And just to reflect on some of the work that they do, and we always talk about restricted and unrestricted funds, but some of the funds that we get that are restricted are really worthwhile and add value to the trust in terms of the offer of art therapy and youth music therapy that is part of the operations and support that we give to our patients. The butterfly project, we have now 27 butterflies and we are recruiting more. We continue to talk with colleagues in the trust about how we can sustain this into business because funding will eventually run out. And it's really interesting to understand now that 2 local GPs are now on board and are talking regularly to our butterfly team. We have our annual bike ride coming up. It seems to come around really quickly, where Steve Good and I tend to hang around Cambridge North Station, sending off and receiving bike riders coming in from a very hot day. But this year we are starting it from Holborn, from Elizabeth House, which is great. And I just want to make a final comment in terms of, we aren't a big charity, but we do provide to staff, and it comes back to the cultural comment that we have been talking about today. We provide moments that matter, whether it's a new kettle or something that they particularly want. The trust charity provides something.
They do, and we should applaud them for it. It's very rare to do a visit to one of our service locations where you don't find something that Head to Toe brought to bear to improve the working lives of staff in small ways and big ways, but also huge amounts of the patient environment as well. So thank you for that, Jackie, an important thing to remember. Steve?
Jackie, can I just also say thank you to the charity in terms of sponsoring what I think are a lot of activities around fundraising which promote health and well-being of our workforce. It's really important that people, get out there, they exercise, they so on. There have been a load of initiatives on Viva Exchange, which is our internal communication platform, and a bit of a shout out actually to Chris, who should be on the line, who is our Associate Director of Comms. People were asked to do 3 miles as a contribution to that. Chris ran 80. Can we just say that out loud? 80 in terms of his contribution. So to our very own Iron Man, thank you, Chris, for doing that. You'd be pleased to know that he couldn't walk for a week after that, but he did brilliantly. So just want to make that point.
Well, we're a caring organisation, so we're not pleased to hear it couldn't walk. We're applauding the fact that he made such a tremendous commitment. Thank you. Can I again then go relatively briskly to you, Mark, for the audit and assurance report?
I can be quick. Our last meeting was the 15th of April. Just picking up a few points. The annual report and accounts, we had an update from the external auditors. Everything appears on track, and we actually have an extraordinary meeting in 3 weeks' time to approve the accounts, followed by the board to approve them as well. So everything seems to be running to schedule. No material items have been raised to me as yet, so I hope that remains for the remaining 3 weeks. But everything looks kind of positive at the moment. There were 2 internal audit reports finalised since the last committee meeting. One got a substantial assurance and one got a reasonable assurance, which I think was extremely positive. We did go through the actions from previous reports, including the one which we raised at a previous board regarding minimal assurance. So we went through and got assurance regarding the closure of those actions, which again I think is very positive. We also got an update from the head of internal audit regarding their draft opinion for 25-26, again, which is very positive in that we'll get a more positive position this year compared to the previous year. So I think well done there. We got a lot of substantial assurance from the work of internal audits, and because we had one reasonable assurance, we got reasonable for the actual reports themselves. But I wanted to be raised at a previous board the difference between when we give an assurance, so the work of audit versus the actual the results of their work, which is different. We also went through the internal audit strategy and plan for 26-27. We noted their areas of focus. They're set out within the documents, so I won't repeat them now. We also received the draft annual report from the local counter fraud service group. Both Robert and I have approved the report electronically. I had to learn how to do it, but that's now been submitted to the NHS central group. Again, positive there as well. And they also took us through their plan for 26-27, which we supported. So those are things I would say would highlight. We've covered a couple of other items like policies previously, so I won't repeat them now.
Could you just clarify for me on the assurance level you've given to policy ratification and compliance?
The process, in other words, there is a process for policies regarding their issuance, the governance regarding it, the tracking. Where we have a partial is actually people doing it. So again, the difference between you have a process, but people are not necessarily following the process, hence the difference.
Okay, but you're presumably getting some data so you can move to reasonable assurance.
Yeah, and that's where, in effect, equally as we just discussed, on making sure we get closer to that 100% level. And I'm happy to work with the teams because I ran policy groups elsewhere to discuss ideas on that as well.
All right, thank you. We'll look forward to that. So then I go to Cambridge Children's.
So this is a report from the Children's Hospital Committee meeting. It was in April, April the 14th. We've got another meeting tomorrow, actually, so there'll be no doubt further updates against most of these headings. So work on the FBC, the full business case, is continuing, addressing each of the business case criteria ahead of the submission, which is planned for later this year. The next few months will be really important in terms of key decisions that will be coming through ahead of that submission. So the key priorities for the project, firstly, is seeking financial and programming certainty from the development partner. That is ongoing. We will want to see the SPV for the design and build to terms coming through very soon to committee. It won't be in time for the committee tomorrow, but it will be, I'm sure, for the committee in July. And once we've received advice on that, we will consider it and bring it back to a board meeting after our next committee meeting, which I expect will be later in July. The operational model for integrated care is continuing to progress, as are the models for integrated research. At the last meeting, we had a really good presentation around the equality and health inequalities impact of the project. Engagement with patients, carers, the workforce was really evident, and an assurance that the assessment will be regularly reviewed, applied and updated as the project continues to progress. And finally, that the highest risk for the project remains around capital costs and capital availability. When we get greater certainty as a project from the contractors in the next few weeks, I expect, then that will crystallise in terms of what that risk is. But I'll thank you. Yeah.
Okay, Steve. It's good to see this project moving forward, but goodness, there's still lots to do on it, isn't there, before we begin to visualise the day it will open. But it's great to see care and attention you're giving it. Any questions at all on Cambridge Children's before we move on? Steve.
Just one, Chair. Thank you, Steve. Just for the minutes, Steve's alluded to there's a partial delay in the approval of some of the governance arrangements. I've sought clarification on that myself as well. Recognising that this is all partners agreeing to something, I'm assured that the delay has not created a longitudinal delay to the business case, and therefore there is no substantial risk. However, just for our minutes, we've made it really clear that the delay should not then form a truncated decision-making for CPFT's contribution. It's a polite way of saying we cannot be rushed in terms of making our own approvals. But I've been assured that that is not the case. So I think we'll pick that up through the committee.
I think as we previously discussed, we will not be rushed. It's not that we cannot, we will not be rushed. It's important to get this right. Okay, so then I'm just moving to note that we haven't used the trust seal since we last met, which is good. And I'm going to invite Martin to just run through questions received as set out on the agenda. So I think, Martin, you're going to tell me we have a question.
Yes, I think Helen Brown or Mike Hyman should go ask it.
Helen, do you want to fill in?
Yes, thanks, Martin. Thanks, everyone. Can you hear me? Okay.
We can, yeah.
As governors, so we've heard all of the reports today, and really it's cross-cutting through that. The question comes from our leadership team, several who are here today, and thanks to Mike for actually formulating the words from our discussion. Mike, would you rather ask the question, or are you happy that I do?
I'm happy that you can. I shall. It would look well looking from a more general point of view rather than the specific finance one that I would tend to give.
And that's what we're trying to achieve, really. As governors, we fully recognise the scale of the Trust's financial challenge and the need to deliver substantial recurrent savings through the transformation and service design. However, we'd welcome clearer public assurance about how these savings will affect our most vulnerable patients and communities, particularly children and young people, people in mental health crisis, older people, people with neurodevelopmental needs, and groups already experiencing inequality. The board papers describe continuing pressures in access, workforce capacity, complaints, safety, and health inequalities, including concerns in children and young people services, inpatient flow, workforce sickness, and only partial assurance in some areas relating to inequalities and patient experience. So could the board therefore set out which vulnerable groups are most at risk, what mitigations are in place, and what clear public indicators will be monitored to ensure that necessary savings don't unintentionally worsen access, safety, experience, or inequality?
Okay, thank you for that. It's a very comprehensive question. I think some of the aspects of it you've heard this morning have been covered through the scrutiny being deployed. I'm going to look to Steve and to Holly, I think, probably to give you a sense of the immense amount of work that goes on. We have a health equality strategy which underpins all that we do, and I think they will probably reference that. But Steve, let's start with you.
Thank you, and thank you to the Governor's leadership team for articulating beautifully most of the daily conversations that we have, both inside the Trust and with our partners across the NHS. The way in which you've written that set of questions is very pertinent to a lot of the conversation that was had directly with the Secretary of State yesterday. And I've alluded to the fact that there are reviews done, but I think you don't want to hear from me. I'm just going to bring in Holly in terms of our operational leads, and Rachel, if I may, from the clinical quality point of view, because both of those are critical. So if I can hand over to Holly.
Yeah, thank you, and thank you for the question. I think hopefully you've heard us sort of articulate that obviously we've got a significant programme of work over the next sort of 12 months to ensure that we're fit for the future and we're a sustainable and effective health provider. All of our programmes of work have a senior responsible officer, and before any of those programmes of work start, we undertake a robust quality impact assessment so that we can identify risks. And some of those risks may be about particular patient cohorts that might be impacted. And then we can understand how we can mitigate those risks. And we have a review process of those quality impact assessments. So this isn't something that we do one-off and carry on. We will review those depending on the level of risk identified in terms of time frames. I think your question about how might we monitor whether there have been risks to vulnerable patient cohorts. I guess that's one of the reasons that I'm really pleased that the National Oversight Framework exists. So I think that having to report those metrics nationally that are around our waiting times, our access, and actually we're expecting this suite of metrics to include an outcome measure. So that's really important. Are we seeing patients in a timely way? And are they getting better? Are we helping them make improvements? So I think our National Oversight Framework metrics will really help us to review whether we've got any pockets of patients that are vulnerable and not being able to access services. I think there's also the development of our patient and carer race equality. So we know that actually some of our most vulnerable patients are also in communities that we're potentially not reaching. So actually how we take that work forward and look at those metrics will be really important. But I'll bring Rachel in to speak a little bit more about the quality aspect.
Yeah, thank you. I think, as Steve said, these are daily conversations that we have, and this is core to our governance as a trust anyway. I was reading a Datix, an incident report this morning to that effect of if service wasn't being delivered as it should be. I would also add, just to support Holly's what Holly said in terms of quality impact assessments and the health equity strategy underpinning everything we do alongside the link with the clinical strategy, that we have two senior clinicians in what you've heard referred to this morning as the engine, our project management, our transformation programme, and they provide very robust check and challenge with the quality impact assessments at source now, and again that check and challenge with the mitigations that's part of our daily and weekly process that we're going through. And the only other aspect that I would add is that within that, those two clinicians link in directly with the teams that have written the quality impact assessments, again at source for any changes that are happening.
I think what you're hearing, Helen, is that the questions you're raising are part and parcel of the daily work running the trust at the moment, in terms of ensuring that there is always thought about those that we serve and the impacts on them. We have to believe, because I think it is true when we compare ourselves to others, that it is possible to deliver good access, safe and effective services within the budget that we receive. That is the challenge all NHS trusts have got to meet. CPFT can't fit an exception. Every decision we make around use of resources is seen in the round. Impact assessments are undertaken. Risks are raised by clinicians and they are taken into account. And we are not and never will be reckless in what we do around seeking to use resources wisely, because our first duty will always be around access and the quality of the service, the safety of the service that we provide. But I think you will probably hear during the course of the coming months, as you've heard already through the forums that many of you participate in, the full and live discussions around how this works in practice and some of the decisions that we have to make to ensure that the resources are going to the right places to serve the people that we all care about and want to see receiving good services. So Helen, I'll come back to you very briefly, but we are due into another meeting very shortly. So I'm going to have to be a little bit curtailing if I can. So do come back in.
I'll try and be very brief, and we didn't mean in any way to reflect that people weren't taking their jobs responsibly or seriously. And we've welcomed the development of the forums and the input from everyone to be able to have better understandings and foresight looking forward and greater levels of discussion. One of the things that we debated was, should we ask this question at the next Council of Governors meeting? And I think we'll take it away ourselves and perhaps come with a variation of that, so that we can have this in the broader context of predicting and identifying, rather than the sort of more negative connotations which weren't at the heart of our question.
Okay, always good to have questions, because it's, as I say, it helps to make sure that we are really challenging ourselves to make sure that we're doing everything that we believe is right for the people we serve. I think, as you've heard me say many times, every conversation starts with and ends with, are we doing the best for the people that we serve with the resources we have available to us? And then Martin, you had one other question.
There was one further question raised after the deadline, which is now 24 hours before the meeting, that regarding access to services that will be answered in writing to the individual who submitted that question. A high-level summary will be placed in the minutes.
Thank you very much. Can I thank all of you, and a particular apologies if you've had any difficulties with sound today. We thought we had sorted out these problems on sound. We're going to have to maybe look at other remedies for public board meetings, because this doesn't appear to be occurring when we've got other meetings involving other people. So I'm not entirely sure what happens when it goes public, but something appears to be occurring for you. So apologies on that. We, as ever, continue to do our best. Take care of yourselves, and we will look forward to seeing you soon. And with that, I'll close the meeting. Thank you so much.